It's my honor to introduce our first speaker, Dr. Van Morris, who is a GI oncologist and colorectal specialist at MD Anderson. He is also coming home as he grew up here in Memphis, and so we're very excited to welcome him to the stage and also welcome him home.
Yeah, good morning, and thank you again to the conference organizers for the opportunity to present today. As Dr. Vanderwald mentioned, I grew up in Memphis. The first color I ever knew or have known is tiger blue, and my cell phone will always be a 901 number, which I'm very proud about. So it's great to come home. And I just want to start as well just by just saying thank you to this crowd. It was as a med student at UT that I worked with the likes of Reed Baskin and Raza Dilawari, Mark Reed, Arnel Polera, and it was there that I first watched Memphians taking care of other Memphians with cancer and grew to love oncology at that time. So it really is humbling and a privilege to be here today speaking to my home people. With that said, I've been tasked to talk about therapeutic advances in colorectal cancer, the real deal or just hype over the next 20 minutes. And knowing my crowd, I thought the actual a more appropriate title may be Therapeutic Advances in Colorectal Cancer, the real deal or just hype, maybe better said, Memphis barbecue or just Nashville hot chicken. So with that said, over the next 20 minutes, I'll be talking about kind of three topics that are of interest particularly to me. The role of immunotherapy as non-operative management in patients with MSI-High locoregional colorectal cancers. The use of immunotherapy as a combination approach in a specific subpopulation of patients with microsatellite stable colorectal cancer. And finally, kind of some of the recent data looking at the role of circulating tumor DNA in the therapeutic management of patients with minimal residual disease. So to start, for patients who are diagnosed with rectal cancer, traditional therapy, as we all know, has consisted of multidisciplinary management of radiation, chemotherapy, and surgery. And depending on where the primary tumor is, while many patients may be cured, this often comes at the expense of can come at the expense of permanent colostomy. When it comes to patients with MSI-High colorectal cancer, we learned from the KEYNOTE-177 trial, the only phase 3 study to date that's reported results of immunotherapy in patients with MSI-High metastatic colorectal cancer. We saw improvements in survival outcomes with the use of pembrolizumab. And as you can see kind of with the tails of these curves, immunotherapy, renders patients with prolonged, excellent outcomes in this particular population of patients. So the question is, how can we utilize, these exciting results in patients with earlier stage disease? And I want to highlight first work that was done by my colleague at MD Anderson, Dr. Casey Ludford, along with Mike Overman, where she and her team collaborated with a group from France. And they looked at 14 patients with MSI-High colorectal cancers. And as you can see, most of these patients had stage 4 disease. They received immunotherapy, and while in the green box, most of the patients had some remnant disease, either stable disease or some radiographic response to immunotherapy. When these patients went to surgery, 13 out of the 14 patients had pathologic complete responses. The one patient who didn't have a path CR had 1% viable cells present at surgery. So what we saw in a very clinically advanced, surgically resectable population, the vast majority of patients had pathologic CRs in this context. Which brings us to data that was presented last month at GI ASCO by Dr. Lumish and her team at Memorial Sloan Kettering, where they looked at this question specifically in patients with locally advanced MSI-High rectal cancers. These patients received dostarlimab, immune checkpoint blockade, for a total of 9 cycles over 27 weeks, and then patients were followed. If they had a complete response, they went to kind of continued observation without traditional therapy, and if they had residual disease, they went on to go receive standard of care traditional therapy for rectal cancer. 16 patients have been enrolled thus far, and she reported on the first 11 patients who have completed their anti-PD-1 therapy. As you can see here in the yellow, most of the patients had advanced, locally advanced MSI-High tumors. 12 out of 16 had T3 or T4 primaries, 15 out of 16 with node-positive status. I think it is important to mention as well that all of the patients were BRAF wild type, and more importantly to me in kind of the context of these results, the median tumor mutation burden was 74, with a range between 38 and 100 mutations per megabase. Thus far, the first 11 patients who have completed treatment, all 11 have had complete clinical responses. And as you can see here, all of the patients who have subsequently gone on to observation have continued to do very well after completion of their immunotherapy, with ongoing complete responses, even some almost 2 years out now. So these data are kind of very consistent with the previous work I had talked about from the MD Anderson French collaboration. So the question is, are we ready to go prime time with this? And I think that we have to remember from the Keynote 177 that an MSI-High status is not pathognomonic for an inevitable response or benefit to immunotherapy. And indeed, from Keynote 177, approximately 40% of patients had out of the gate lack of response, as you can see in the red here. Interestingly, while we think of BRAF V600E mutations as being poor prognostic biomarkers, it doesn't appear that a BRAF V600E status that those patients did have benefit with immunotherapy as well. So, why are we not yet ready to take this based on this, these two observational cohorts? And I want to just highlight some kind of retrospective work that's been done by various groups looking at patients with MSI-High GI cancers. And they used various cutoffs, as you can see in the red here, to define tumor mutation burden high versus tumor mutation burden low. And even within the MSI-High tumors, again, in these retrospective series, the patients with TMB low, as the authors defined it, MSI-High tumors seem to fare worse with immunotherapy than their TMB-high counterparts. If you look at Dr. Lumish's cohorts, again, the lowest TMB was 38, so every patient on her study would have been in the TMB-high in these particular categories. So it's very intriguing data. We're seeing sustained complete clinical responses in most patients reported thus far with MSI-High locally advanced colorectal cancers. It's safe, it's well tolerated, it's very exciting and promising, but I think further data still are needed before we're ready to go into routine management. And I just want to highlight one trial that's looking at this prospectively. Dr. Kristen Siambor up the road at Vanderbilt University has a trial kind of looking at Nivo-Ipi as a upfront therapy in this particular context. So we'll move next to the clinical problem of BRAF V600E mutations. These occur in around 8 to 10% of all people with colorectal cancer, and we know that when a patient has a BRAF V600E mutation, the prognosis is very poor. These patients do not respond well to systemic chemotherapy relative to their BRAF wild-type counterparts. And just 3 years ago, the phase 3 Beacon trial was published in the New England Journal, where it showed that the use of targeted therapies against BRAF and EGFR. In their study, it was encorafenib and cetuximab, improved survival outcomes relative to standard chemotherapy. So while this is exciting and it was a first step forward that led to an FDA approval of this combination, the reality here is that, as you can see, the median PFS with this combination was just 4 months. The overall response rate was just 20%. So it's a step forward, but we need to do better. So what about the role of immunotherapy in this particular context? We know that relative to their BRAF wild-type counterparts within the MSS-CRC population, BRAF V600E may be a subpopulation of MSS-CRC that is characterized by increased immune activation. One way to look at this is to look at consensus molecular subtyping of colorectal cancer. This is an RNA-based annotation which characterizes colorectal cancer into one of 4 CMS types, for which CMS1 is the type for which is often associated with increased immune activation and infiltration, immune cell infiltration. So in general, as we would expect, MSS-CRC is characterized by a non-CMS1 phenotype. And this clinically makes sense. These patients don't respond well in general to immunotherapy. We looked at data from the SWOG 1406 study. This was a SWOG study that looked at a BRAF EGFR combination in patients with BRAF mutated CRC. And when we looked at their CMS types within MSS CRC, as you can see here, the MSS BRAF mutated patients were enriched for this immune activated CMS1 phenotype. There's also interesting data which has come out of Italy preclinically, where these Italian investigators looked at a microsatellite stable BRAF mutated cell line. And what they showed was that in cell culture, when you treat these cells with a BRAF EGFR targeted combination, you induce a decrease in expression of the MMR genes. And in doing so, what's happening is you're potentially flipping the status from an MSS to an MSI-High phenotype, at least in vitro. And kind of along that thread, when we've looked at paired biopsies, one example of which you can see here, of patients who received a vemurafenib, cetuximab, BRAF EGFR combination at MD Anderson, when you look at paired biopsies between pre-treatment and on-treatment specimens here, you can see that BRAF EGFR, in this particular example, induced a recruitment of activated T cells into the tumor microenvironment. So the question is, can we prime these MSS BRAF mutated tumors for response to immunotherapy with BRAF EGFR inhibition? And we looked at this at a trial at MD Anderson that we reported last month. Patients with microsatellite stable BRAF mutated CRC were enrolled and received the combination of encorafenib, cetuximab, and nivolumab. To date, we've treated 26 patients, and last month we reported the outcomes of the first 22 patients to get restaged. And what we saw was that in the first 22 patients to be restaged, an overall response rate of 50% and a disease control rate of 96%. And again, we can't compare these head-to-head, but keep in mind the historical context from the Beacon study of encorafenib and cetuximab was an overall response rate of 20%. Similarly, the median progression-free survival that we've seen thus far is around 7.4 months. For the patients who have been on study, the median overall survival is 15.1 months with the addition of nivolumab to encorafenib and cetuximab. Again, the historical context with Beacon, the median PFS was 4.2 months. The median overall survival was 9.3 months. Our results are consistent with the reports, with other data which have been reported out of the Massachusetts General Hospital, Dr. Ryan Corcoran and Dr. Aparna Parik's team, where they looked at a BRAF MEK PD-1 combination, and again, in the same population, and again, saw very promising response rates and duration of response in a small number of patients. So again, this theme of MAP kinase inhibition with concomitant PD-1 appears promising, but as I talked about with the rectal cancer example, while this appears to be a safe, well-tolerated, and potentially effective, promising combination, I don't think we're there yet. And the SWOG 2107 study will be opening later this summer, which seeks to address this question more formally. In patients with microsatellite stable BRAF mutated CRC, the addition, looking at the benefit of the addition of nivolumab to encorafenib and cetuximab, and 75 patients here will be randomized in a 2-to-1 fashion to receive the combination with or without anti-PD-1 therapy. For the sake of time, we'll go quickly through the kind of last slides. The role of circulating tumor DNA in cancer. We know this is a highly sensitive, the detection of mutated tumor DNA in the blood or other cancer-specific DNA components in the blood is a highly sensitive way to detect minimal residual disease. As it stands right now, we're still kind of learning, I think, where exactly this fits in our day-to-day management, just based on the limitations of the exciting data that's come out thus far. ESMO and the NCCN, they still continue to really recommend clinical trials kind of in this setting, but the potential applications of circulating tumor DNA in the management of oncology in general is very wide and exciting. Briefly, we'll talk a little bit about the GALAXY data. This was data from Japan where they looked at over 1,000 patients with stages 1 to 4 colorectal cancer, and they collected circulating tumor DNA at specific time points and kind of watched, what happened, to these patients. I could talk for an hour just about their data, so I'll try to do my best to distill this down. But as we saw, kind of at a 4-week time point in the postoperative setting, a circulating tumor DNA negative status was associated with a very favorable prognostic outcome, whereas patients who were ctDNA positive, didn't fare as well. Again, this points to the presence of circulating tumor DNA as a surrogate for residual disease, most likely microscopic disease. We just don't know if that means disease locally at the tumor bed site, or if that patient has already developed widespread occult distant metastatic disease. So again, for the sake of time, just keep moving. The clearance of circulating tumor DNA, I think, is the question. If a patient is ctDNA positive, what do we do kind of with that information? And the numbers are small from the GALAXY data, but patients who cleared their circulating tumor DNA in their particular cohort, as one would expect, would fare better, whereas patients who had residual circulating tumor DNA and did not clear fared worse. It's interesting, though, in a similar observational kind of effort that was reported last year at GI ASCO from a European group using the same exact ctDNA assay, they saw that patients that in a small series, for patients who are stage 3 disease who are ctDNA positive after surgery, only 20% of these patients were able to clear and not recur after completion of their chemotherapy. And the figure is small here, but you can see there are cases where patients convert from positive to negative and then convert back to positive. So there is some flux in kind of ctDNA status that has been observed. I just want to highlight, so one would think, well, if they're ctDNA positive, we should be treating these patients with adjuvant chemotherapy. This was data that was presented or published in Cancer Discovery last year, looking at gastric cancer. But what they showed was that that chemotherapy, standard chemotherapy that we use in GI cancers, is able to modulate the tumor microenvironment and induce a less favorable immune phenotype in that context. So, if a circulating tumor DNA I'll just throw out there, if a circulating tumor DNA status does, represent the presence of already disseminated microscopic disease, it may be in those cases that we have patients who already, unfortunately, are incurable. We're just detecting that earlier with the ctDNA status. Is it possible that we're already modulating their tumor microenvironment and affecting potential options for immunotherapy down the road if they're not going to be able to be cured anyways, just by virtue of their disease? It's an academic question, but just kind of interesting. I'm going to highlight briefly just a couple of trials which are looking to understand and provide much needed level 1 evidence for circulating tumor DNA. The NRG GI005 trial is looking at low-risk stage 2A colon cancer patients. Patients are randomized to either standard of care or prospective testing, and patients who are discovered to be ctDNA positive are thereby treated with a fluoropyrimidine oxaliplatin combination. The NRG-GI008 trial is soon to activate. This is led by Drs. Arvind Asari and Chris Liu at Colorado. Again, looking at the question of de-escalation for the prognostically favorable ctDNA negative patients and escalation of chemotherapy in the prognostically unfavorable ctDNA positive patients. And then I think a really interesting study led by Dr. Aparna Parikh at MGH, which is looking at patients who are ctDNA positive after completion of standard of care therapies, where patients receive respective targeted therapies tailored to their various molecular phenotypes. So I think this is, a very exciting prognostic assay. We're still missing the needed, I think, level 1 evidence for demonstration of predictive utility in this context. We could talk for another hour about how the biology of micrometastatic disease likely differs from that of macrometastatic colorectal cancer, and we should be incorporating this into, our clinical thinking and trial design in the future. And again, there are trials which are coming out of the woodwork now, very much needed to look at this space. So thank you for your time, and I'll turn it over.